Patricia McKeown, the Regional Secretary of UNISON, and a number of colleagues to the table. Patricia, I'll ask you and your colleagues to introduce yourselves to start with, and then, as with all other witnesses, we will ask you to make a short opening statement, and I will keep you reasonably close to time, and then we'll have a number of questions for you, and then we'll finish with any final comments that you wish to make. So if you'd like to introduce yourself and your colleagues, and then we'll go to the opening statement.
Okay, I think we'll do it individually, Chair. It's easier for me.
Yes, yep.
It's a great team, though. I am the Regional Secretary of UNISON, which is the largest trade union in the health service in Northern Ireland. We cover all disciplines except medicine, although we do have the odd progressive doctor who joins. I'm also co-convener of the Equality Coalition alongside our human rights NGO, the CAJ, which covers a large number, I think almost 100 now, civil society organisations intent on challenging government and the public system to meet its obligations under our equality laws. And we are also on the board of the Human Rights Consortium, which is an organisation of over 200 civil society organisations here, with a primary aim of having the promise of a Bill of Rights and the Good Friday Agreement delivered, and other outstanding commitments in the agreement delivered. So equality and human rights are fairly central to everything we do, particularly in respect of the health and social care system.
Okay. Do you want to start there and come round that way then? Yep.
I'm Jonathan Swallow. I'm a consultant and advisor to UNISON on this and other issues of health policy and public procurement.
Thank you.
Good afternoon. I'm Owen Stewart. I'm a charge nurse in accident emergency in the Mater Hospital. I've worked there since the early 90s.
I'm Stephanie Greenwood. My substantive post would be in pharmacy in Antrim Area Hospital. I've been seconded for the last number of years as Joint Branch Secretary for the Northern Health Trust.
I'm Joe McElhatton. I'm a nursing auxiliary in the Royal Victoria ED Department, ex-Belfast City Hospital A&E Department, and I'm here to represent my members in the ED Department.
Thank you.
I'm Pat Neeson. I'm UNISON Health and Safety Officer in the Royal Hospital, and I'm also an ED porter.
I'm Ray Rofferty. I'm an employee of the Health Service for 30 plus years. I'm Joint Branch Secretary for the Royal Hospitals branch of UNISON, and also co-chair of the Trust Health and Safety Committee for Belfast Trust.
Okay, thank you. If you'd like then to start by making the short statement, and then we will have a number of questions that will follow from that. So the floor is yours, Patricia.
Thank you. For the past 16 years, we've been providing evidence of the failure of our government and our health system in particular to meet their devolved obligations under the state's obligations under all of the international human rights treaties, conventions and other instruments they've signed up to. It's been a particular feature of the health and social care system. It's particularly important to the people because polling 2 years ago by the Human Rights Consortium demonstrated that in the 90s, the voters for all of our political parties supported Bill of Rights. They put social and economic rights at the top, and they put health and social care at the top of that. We were very enthusiastic when our new government first took office because they conducted a comprehensive review of the state of the health of the people, first one ever conducted. It produced stunning results on how poor our health inequalities or how high our health inequalities were. And the Department of Health and the Minister for Health of the day responded by producing what was our public health model. It was called Investing for Health, and hailed by Sir Donald Aitchison, who was at that point, I think, the chair of the English health system, as the best health programme he had seen in the English-speaking world. It was not implemented. A decade later, the Chief Medical Officer, who I believe recently gave evidence to you, made public the fact that during that period, life expectancy had reduced and premature death rates had increased for people living in the most deprived societies in Northern Ireland. Those are also the societies most impacted, communities most impacted on by the conflict. And in addition to that, our suicide rates during the 16 years of peace process now outstrip the number of deaths in the 40 years of conflict. And that has happened, in our view, because that excellent public health model was not implemented. It has now been replaced by a pale shadow. The equality and human rights dimensions have been stripped out. We also have a new model to reorganise once again our dysfunctional health service. It is dysfunctional. And that model is heavy on aspiration, short on implementation, and in fact most of the actions being taken operationally at the moment go counter to the concept of bringing care nearer to the people. Had our original model been implemented, it would have begun to release the pressure on our acute system. That has not happened, and in fact the pressure has significantly increased over those 16 years on the acute system, and that is one of the reasons we find ourselves in the difficulties we do today, particularly in our A&E departments. But that is one of the difficulties. We've given quite extensive evidence to various inquiries and to the system itself as to actions that could be taken to correct some of the problems we're facing. I'm going to ask Jonathan to come in because you've already had some of this information in writing from us.
Yeah. Okay, Jonathan.
We've done an analysis of a system that is failing and deteriorating as we speak. The targets, waiting times, are desperate in comparison with the rest of the UK. They continue to deteriorate. That information is presented monthly to the Health and Social Care Board. As a participant observer of their proceedings, I have seen no effective challenge or search for root causes in the last 10 months as that information comes out. We have challenged objectification, inappropriate phrases. The latest one appears to be handbag positive. And we have said as a union that is a wrong culture to discuss and describe these issues. We've challenged the blaming of individuals, particularly those in deprivation. We will not accept going back to the 80s where those in need are blamed for their poverty and ill health. We have said very clearly there is no proper establishment of posts and skills and skill mix to do the work, to be accountable, and there is a failure sustained in recruitment. So I, in any other context, would expect it to have seen a work-measured establishment. I have not found one. We have pointed out to you that there is no physical standard, either in terms of space or facilities, to protect dignity and waiting times. Human rights became a topic of discussion at events we attend when your commission announced its investigation. Before that, we did not hear the language of human rights. We did hear the language of patient experience, dignity, waiting times. It's an important language, but it needs articulating in human rights terms. There have been substantial closures of facilities. We have been told on each occasion these were for clinical safety. We have then found in commissioning and delivery plans financial savings attached to those closures. The same issue arises with the 5-year purge on bed numbers and the sustained failure to meet the 85% bed occupancy standard, and those to us are critical system issues in the difficulties and degradation of rights that are taking place in these facilities. I have to say to the Commission, it is my view as a participant observer at the Health and Care Board for the last 10 months that executive directors and officers are protecting past decisions made for financial and not clinical reasons, and that disconnect is preventing the genuine partnership and transparent working that is needed to put this right, and preventing the access to funds that is needed to put this right.
Jonathan, I'm going to give you 1 more minute if that's okay.
1 more minute.
Great.
Is my last point left.
Great.
We have also identified to you that in any good public or private organisation, whistleblowing would be communicated and its policies through small group regular briefings. I led the UNISON programme on whistleblowing. Very few of the attendees had even seen the trust policy, which had been placed on the intranet. So there is a fundamental communication issue there that, again, in our view, is damaging to rights. Thank you.
Thank you. I'm going to kick off, and you may well obviously want to ask Patricia, your colleague, so while I'll address the question to you, others may well want to come in on this. I think my first question is really, and in the context of the emergency department, and that's what this inquiry is looking at, is what do you see are the key resource and non-resource issues that face your members working in the emergency department, and how would you go about dealing with those particular issues and challenges?
I could
immediately
answer
I
that.
think we hear from the 3 different emergency departments we have here, because each of them has done what you've just asked.
Great.
Chair.
And I'm going to ask, because I suspect all the questions we'll have, one of the things we're interested in is whether you see some of the issues as being site-specific or whether they are endemic across the hospital. So it'd be very helpful, given you've got a number of people in different places, if you, for example, think that hospital A or B is particularly good or hospital C or D isn't. Endemic. Then let us know. So, Ray, go ahead.
Say who you are.
Ray Rofferty, Royal Hospitals. Two quick things about this, but it's going to answer both the regional and the specific aspect. It's almost 9 months ago, whenever the emergency was declared within the Royal Hospitals. Yep. We had a situation where there was almost 40 people on trolleys waiting for beds. There was 100 plus people in the A&E department waiting to be treated. The staff were at their wits' end. Stress levels were exceptionally high. They are totally professional, do their best. It was a point of meltdown. That was 9 months ago. Quite a lot of intervention has happened since. The last 2 weeks have been exactly the same. Most days we have 30 plus on the trolley wait. We have 100 plus attending ED. By the end of August this year, we had the same total number of attendees in ED as we had for the whole of the previous 12 months in 2013. It looks as though there'll be a 35% increase in the number of patients. What I would like to say is this isn't just a picture for the Royal. This is endemic across the region. The problem that the Royal suffers is it's the hospital of last resort. It's at the end of the motorway, and as other people close their doors, the drift is into Belfast. The problem is the system can no longer cope, not because EDs are inefficient, because they don't work. They are not hospital wards, and on a daily basis they are treating 2 wards worth plus of patients who should be in hospital beds being treated by the right doctor in the right department at the right time. That's not happening, and if that's not happening, then people's human rights are being totally and adversely affected. More than that, the rights of the staff to provide a professional care within a safe working environment is being totally eroded. Their health, their welfare and their stress levels are totally out of control because of the unfair demands. The bottom line is the services have been cut for many years. The acute provision has been reduced. There's not enough beds. We end up with patients and no beds to put them in. That leaves the pressure within ED. That's now the front door of the hospital system. And unfortunately, that's the area that an awful lot of people in dire need are stuck in for not 6 hours, 12 hours, 24 hours plus quite often.
Okay.
My background is I work in the accident emergency in the Mater Hospital. And the Mater Hospital, I will say, is an absolute brilliant hospital. But over the last 4 or 5 years, it's been totally reconfigured to something that you won't recognise from what it was 5 years ago. Now, the whole theory in that was the Belfast Trust theory was the right patient in the right place at the right time, which I totally understand. But I was at your session on Friday, and it was great to hear the patient's story. But I do think it was a very big pity that some of the trust representatives didn't stay to hear the patient's perspective on what had happened to them. So I would like to give you to let you know why this theory of the right patient at the right time in the right place doesn't work. And this just happened on Monday, and I spoke to very senior nurses in accident emergency in the Mater Hospital who are deeply, deeply upset about this. 33-year-old gentleman was admitted to accident emergency at 6 minutes past 6 on Monday morning. He came in with headaches. He was diagnosed that day with a massive brain tumour. and he needed neurosurgery advice. The neurosurgeons couldn't see him, who are based in the Royal, not based in the Mater, because we don't have surgeons in the Mater Hospital anymore, because that was reconfigured to the right place at the right time. The neurosurgeons are going to have a case conference about this gentleman sometime this week. This gentleman's 33, massive brain tumour. He was eventually admitted to a bed in the Mater Hospital at 25 minutes past 6 that night. More than 12 hours wait, and he most certainly isn't a patient in the right place and at the right time, because he most certainly, no matter how much I defend the Mater Hospital, shouldn't be in the Mater Hospital. He should be in the Royal with the neurosurgeons, where he will get the best treatment. The same day, an 87-year-old woman came into Exeter Emergency at 5 to 12 in the afternoon. She required admission. The decision to admit was very quick. She was seen very quick. The bed that she was going to get was in the City Hospital. The ambulance was ordered at 5 to 5 that evening. The ambulance didn't turn up to 11:45 that night. That lady lay in the Exeter Emergency Department all day by herself. At the time, on Monday at 5 o'clock, there was 20 other patients waiting on admission. And when I left at 5, there was another potential 6 on top of that. That most certainly isn't the right place, the right patient at the right time. To the credit of the staff keep coming in on a daily basis and are faced both in the Mater and in the Royal with these situations. And to their credit, they're not going off sick because they see that the care of the patient is priority. But this can't go on, because the only impact on the staff is stress is going to go up, and the patients and the relatives see the stress that the patients are on, and at stages the patients are actually becoming the patients of the nurses because they are comforting the nurses. That's not why they're in an Exeter Emergency Department. They're in an Exeter Emergency Department so the nurses can comfort the patients.
Stephanie? Stephanie Greenwood, Antrim Hospital, Northern Health Branch. It's my observation, and that of the staff that I represent, that they are excellent on-the-ground nurses and support staff, but they're working in a climate where they're working with an ethos of a trust that will do the tick box exercise. They will put the paper policies in place. They will populate rotas legally, but no matter how inappropriately those rotas are put together. They will provide incident report books, but they'll put them under lock and key. The reality of the situation is that the skill mix on those rotas is not correct. For example, if you had 16 nurses, you have 4 with experience, 4 agency, 4 nurses from other departments that have never set foot in an ED department. Incident forms, there's a climate of fear, of retribution if the nurses complete them and fill them in. That's if they can get hold of one in the first place. That's if there's availability, and that's if they have the time to fill them in. And there's no feedback when they do complete an incident form, so they're disillusioned now, and they think, what's the point? They're forced to put medical patients into a gynae setting, for example. As long as they're off the ED computer, as long as they're somewhere else, as long as it appears that the ED is functioning, it doesn't matter about the patient's dignity. It doesn't matter about what the nurses, how compromised the nurses are feeling. Those patients are moved to perhaps male patients, to female wards, to fire exits, to sitting below, to be bedded below windows, to have inappropriate blankets and coverage. That all disappears if there's a planned inspection. That goes on day and daily within that hospital. But if there's a planned inspection, that goes away. Ambulances are diverted to other hospitals, and patients are inappropriately discharged to provide an overall picture of an ED department and a hospital service in Wales, which is a complete untruth. In Antrim Hospital, the biggest requirement and the biggest resource needed is quite simply more beds. And perhaps a concession that they made a very rash decision in closing the White Abbey and Mid-Ulster A&E departments. It's a very large geographical spread, unique rural environment they're trying to cover, and it was a very rash decision that they closed those A&E departments over a period of 10 days a number of years ago. They need to improve the community infrastructure and funding and the out-of-hours service. improve staff consultation and practices. The staff I represent don't get a big enough voice at an early enough point in any part of consultation, and they are quite simply not listened to. That's another tick box exercise within that trust. And the biggest change that they need to make is in their culture and values. There is a climate of bullying and intimidation of staff, and it has to be brought to the point where staff can sing freely about bad practices that are going on.
Okay, thank you. I'm going to ask one quick supplementary on that, and then I'll come to the issue that you've raised, which is the kind of staff involvement in planning, and I'll ask colleagues to pick up the issue of the culture and that you've mentioned. I mean, one of the bits of evidence we've had, particularly around the Royal, was that that there are now some extra resources have been put in as a result of the RQIA inspection and all that happened, particularly on the nursing side, but that was non-recurrent, and therefore one of the concerns was how long those resources would last. So two questions. One, for example, in the Royal, have you seen those extra resources? And if so, what difference, if any, is that actually making?
Yes, we've seen the extra resources. I think the important point, and one which has been missed, is because of savings over numerous years, recruitment basically slowed down to the point where it was the odd staff was replaced rather than all staff being replaced. The number of nurses that have now been employed for the Royal, and I believe it's 25 in the last lot of months, are actually only filling the gaps that were there previously. And quite a significant number of those 25 recruited have subsequently left because of the pressures and the volume of work and the ability to cope with it.
Can I just give one answer in the back of that as well? More staff isn't the answer, because you have more staff then falling over each other. We need beds in the system. We need more beds. There's hundreds and hundreds of beds closed in the Belfast Trust alone. So when you have more staff in an accident emergency department, the patients aren't going anywhere because there's no beds to put them in. So all the extra staff, yes, we need the proper staff and establishment, but more staff are just going to fall over each other.
The system is operating and has been for several years at 95% plus bed capacity. Yes. There's a direct correlation between that and cross-infection. We brought that to the Minister for Health and right through the system. We've even established a small project in a small way across the Royal and the City Hospitals to try and tackle some of that, but in the absence of beds, too many were closed. In the absence of beds in a system that is still increasing in demand on the acute side because it's not paying attention to a public health model, this is going to get worse.
Okay, and then my final question before I pass you to Marion is, and you alluded to this in answers, we've heard a lot of evidence that the trusts place great value and emphasis on involving staff in planning services and clearly suggesting that is a tick box exercise. So I wonder if you'd say a little bit more about what, if anything, they do, and give me some examples of where suggestions have come from staff in terms of dealing with these matters that are not being heard. So,
Could I start with equality and human rights and say that in the room today I spot some of the Trust's equality and human rights officers, small number of people, dedicated team across the different parts of the health system, frustrated, ignored, not included in the senior level decision making processes, not included to any extent in the policies that are being trotted out now almost on a daily basis. So the system has got good people with the right knowledge and the right skills. They are not there to be heard, and that's very disturbing.
okay.
But when they talk to you, they can demonstrate that there's an equality and human rights framework. Also inside the system, UNISON for the last 15 years has been pioneering partnership work inside the health system, and we have changed the way people work. We have directly engaged across the whole workforce. We've even had doctors and senior doctors in rooms with hospital cleaners to talk about better ways of responding to the healthcare needs of patients, challenging cross-infection, doing things in a better and different way to improve the health system. We have won UK-wide awards for doing so. But that is on the fringes of the system. That is something that is an additional time burden on the people on the health side, from the management right through to the frontline workers involved in these projects, an additional burden on us. It is not a way of doing business, and we think it ought to be a way of doing business. We have been working for years with local communities on how they should be participating in the processes about their own healthcare. They're excluded from decisions about their own lives and their own healthcare system. There is tokenism. There's the odd project out there, and you'll find that there are a few community, usually community workers as opposed to actual members of communities involved in those processes. We were much better at this 20 years ago than we are today. Today we have buses going through Northern Ireland with adverts on the sign saying, ring us, we're the Patient Client Council, and we want to hear your views. So our experience, if there's been no proactive work done to involve people in decision making or inform them of their rights, then you're not going to get what you want out the other end. And yet, that first public health programme that was developed here in 2001 had one of the most extensive outreach programmes I've ever seen. It was a shining example of how a government and a government department could reach out to people across all sorts of categories, including the most vulnerable and the most disadvantaged, and get them into a process where they were talking about their own needs. All of that has been dropped. So today, in this new part of the health system, it was restructured almost 7 years ago now, and the 6 current trusts were created. They should have been abolished. The current health board was created 2 years after the trusts. The Public Health Agency, which we supported, was created, and we saw it as the potential champion of a public health model. It has not exercised its challenge function. It hasn't exercised it, and it's admitted to us that it hasn't challenged either the Department of Health or the Regional Healthcare Board in these decisions that they take about people's lives. So it's failing. It's very good on the small projects. It's not big on the challenge function. The direct engagement with unions is something that happens in a box now. The direct engagement with the workforce itself only happens if we can talk somebody into a project which directly involves them. I heard evidence from the PHA there that it's got all sorts of health workers involved in these programme boards for 10,000 voices. Talk to us. Tell us who they are. Yeah.
The
Okay.
RQIA report into the ED department and the RVH this year concluded in part of its report a culture of bullying. Whenever there's a culture of bullying, it's very, very difficult, if not impossible, to engage with staff, to get them to freely come forward with their ideas, their concerns, and progressive methodology. Instead, what we have is a system of fear where people are afraid to report the issues and the concerns. Hopefully that's less than what it was a few months ago. Unfortunately, I believe that it's still ongoing.
I feel very frustrated sitting here today, listening to the previous speakers. I am a porter in the hospital, and I know absolutely nothing about 10,000 voices. I don't know a porter who's involved in 10,000 voices, or a domestic, or a catering assistant, security. I don't know anybody who's involved in it other than one lead in our A&E department, which is Glenn Little. I know he's involved in it, but what they do, I haven't a clue. I really don't know anything about 10,000 voices or anything else that they're trying to promote within the trust that has staff involvement. Staff involvement doesn't exist. Everything that we've stepped forward to, and this is not coming as a trade union member, this is coming as a member of staff, and everything we put forward to try and improve the service that we expect to provide is basically management are turning around saying, you don't make the decisions, we do. The unfortunate thing is that they're making the wrong decisions, and it's costing the trust a small fortune. More importantly is it's running the risk of costing people their lives, the decisions they're making. I have 2 roles in the hospital. One is a porter, and I get the responsibility of taking a patient to the ward. maybe after they've spent 22 hours in a trolley in the A&E department, with their dignity, their self-respect has been taken away from them, they've been stripped of it, not because of what the staff are doing, but because of what the trust are doing. You walk in these departments and you see elderly patients with dementia, and the only dignity they have is an incontinent nappy to keep them covered while they're pushing the blankets off themselves in a department that's packed with total strangers. We have 4 doors into our ED department in the Royal Hospital, and they're broke. They're constantly broke. In my role as health and safety officer, I've reported these doors several times, week in, week out, for this past couple of years. They're still broken yet. Every Tom, Dick and Harry in that hospital uses our ED department, our outcomes area, our focus. Every part of that department is shortcuts to where they're going. People use the front of the A&E department as a car park. They come in for, I've watched people driving in there delivering Chinese takeaways into the hospital, and we can't get ambulances in. God forbid there's a major fire in that hospital, because I'll tell you now, the fire service won't be able to get in to save anybody in that hospital. It'll be down to the staff on the ground trying to do their best with meagre resources, trying to actually get patients to an area of safety. And the other role that I do in relation to my health and safety is around the staff themselves. Trust me, come in sometime when the staff don't know that you're coming in, when it's totally secret, and sit in one of them areas where the staff are congregated and listen to the heartbreaking stories that they tell you about what it's like to work in a department that's breaking their hearts day in, day out.
Okay. Thank you. I'm going to, because I'm conscious of time, I'm going to pass you to Marion, who will talk a bit more about some of the staff culture issues that you've already raised.
Thank you very much. Good afternoon, everyone. Ray and Stephanie have already mentioned the RQIA report in the Royal and the bullying, and my question really relates to bullying, and I'm wanting to know, does that report accord with your experience? That's the first part of the question. Is the Belfast Trust effectively dealing with bullying? And the final part of the question is, to what extent is the bullying that was referred to in the Belfast Trust found in other trusts, including the Ambulance Trust? And have you any examples of good practice in that area, as well as concerns?
Could I give you a quick overview, and then people would tell you direct experience? We, as a union, were responsible for incorporating the right to whistleblow in people's contracts of employment across the NHS in all 4 countries. As part of the Agenda for Change, there's a clause in there. We followed it up here with a series of training sessions, and Jonathan's made reference to those. Waiting lists developed to get on those training sessions. At the same time, our members, particularly in nursing, were reporting to us that in very large quantities for a very long time, those who had got access to the incident reporting forms were completing them, but they were going into the system and nobody knew what happened. We brought that challenge to the 5 trusts and to the Healthcare Board. We also raised it with the Minister for Health. We said that we thought it might be appropriate that those incident report forms were analysed, that was publicly available data, and they might at least consider it at their monthly trust board meetings as an agenda item, and that the Healthcare Board itself might consider those issues at least on a quarterly basis at its public health meetings. There's been no response to the system from the system for any of those proposals. We had to go public. There is still no response from the system to those proposals. I'll ask Stephanie to come in, because we have just most recently dealt with a very serious issue of bullying of nursing staff in the Northern Health Trust, precisely over the issue of them wishing to complete incident reporting and to raise the range of problems, many of them related to the lack of staffing levels or the wrong skill mix. And obviously they're obliged under their code to raise it, make it known, get it through the system. The response has been bullying and harassment. In fact, I think we've had to have apologies. We've actually received unheard of apologies in the last couple of weeks. You might want to say.
In terms of how rife is it, it's I can't put it into words. It's horrendous. It is absolutely underpins everything that the nurses and nursing assistants and support workers do on a daily basis within the hospital.
Is this just the Northern Trust we're talking about? Or is
I would imagine my colleagues will support that and say it's over it's across the province.
But you're talking about Northern.
I can only speak about the Northern. It underpins everything that the nurses do. If they argue something on the grounds of clinical need or safety of patients, they're threatened with discipline. They're told that they're not entitled to that opinion. We have on 2 occasions the ED department. It took over a year to get management to come down into the ED department and apologise to our nurses for a bad practice incident. It was a training incident. It was a piece of really bad practice. It should never have happened. And it took over a year before we could persuade any level of management to come in and apologise to those nurses. Recently, we've also had another group of nurses in one of our medical wards who have received an apology, but it took me intervening there again to have those nurses apologise to for being threatened with discipline because they wouldn't carry out a procedure which jeopardised patient safety.
Can I just clarify, are we talking here about managers in the health service or clinicians in the health service or both? Or
Both.
Okay.
There is a culture in certainly the Belfast Trust of management informing staff that they do not have to fill in forms, IR1 forms, that they shouldn't go to their trade union and ask for advice. I had 2 members of staff this morning talking to me about exactly that. But there's also a culture, I believe, of our politicians bullying the local community. When our health minister goes on the local radio and says he's going to start charging people, or he's thinking about charging people who have any alcohol-related diseases when they come into an accident emergency department. So that culture is from the very top going the whole way down.
If I can just have a quick word before Joe makes a direct comment about ED. Whenever demand outstrips supply and targets cannot be met, there is a natural methodology of push, demand more. That is endemic within our health service, not just in the ED departments, but in all the wards and all the departments. And it is at crisis point at the minute. We have staff who cannot cope, not with the workload, not with their professional standards, but with the undue demands being placed on them by their senior management to meet totally unrealistic targets.
Do you want to say
Hi,
something?
so I'm Joe from the Royal ED Department. And we'll go back to where the bullying all started. The staff were that afraid. They went on to 10,000 voices to express their fears and concerns. And all the staff and all the departments and all the hospitals, priority is patients first. Now, they were afraid to complain of being bullied, of being put into Coventry, which had happened to one of the senior sisters, because they spoke up and they voiced their opinion. Now, only for the guy doing the 10,000 voices, Glenn Little brought it to the attention of the senior managers within the Belfast Trust that the staff were that terrified they had to go there. Now, that wasn't a format for the staff at that time, so they had to go on that and write their fears and that in it. Now, this is serious. Our staff give 100% every day. Every day they go to work, their registration's on the line. Our doctors, our nurses, our porters and all are under pressure every day. And they do the best job they can do with the resources they have until you put in more finance and to improve the community, the care services in all the hospitals, and especially the mental health team are getting shortchanged. We need more money there, and we need it now. We do not need it in 2 years' time. We've sat and talked for 10 to 12 years on what we're going to do, what we're not going to do. Let's put this aside. Let's get it done. Stop messing about. People's lives are on the line.
What we would like to see is more senior people speaking out. They are confiding in us. They are leaving the service. particularly acute at the social care end of things, where very good talent and dedication has gone out the door because they have been threatened. They have raised internally. They've been told that it's not acceptable. They've got to do X, Y, or Z. They're not prepared to morally or ethically do some of the things that are being required of them, and they're leaving. Unfortunately, I keep criticising them and saying to their faces, I would rather you spoke out publicly, because you speaking out publicly is worth 100 times us speaking out publicly. We are accused of having a vested interest. But at the end of the day, you know, this is happening across all trusts. It's happening across the system. The places that are feeling the pressure to an extraordinary extent are not just, as Ray says, the NE departments. The social care end of the process is in very, very serious trouble, as is mental health. And our mental health system was chronically underfunded when this new government came into being, and nothing has happened other than some tokenism to put that right. And that underfunding results in more people coming into the A&E departments. And the other thing that has been happening, we have very, very clear evidence that the the categories of people, and you know, Owen would give evidence in this, the categories of people who are discharged back out into the community because it is assumed they can take care, self-medicate, take care of themselves or whatever. Not much attention given to whether there are or are not mental health problems there, coming back into the system as much more acute patients very quickly afterwards. We have a local human rights organisation that was founded by my predecessor, our leader Inez McCormick, who's recently deceased, and it's called the Participation and Practice of Rights Project, and it works across some very deprived communities in Belfast and further afield on a cross-community basis. One of the big campaigns they ran was called, it was about being presented with a card. When you presented yourself in a suicidal state at an A&E department, you would get a card that guaranteed you an appointment. That was wonderful victory. It was launched by the Minister for Health in conjunction with the group. Nobody in the healthcare system told anybody on the reception desks of our hospitals that this was now the process. People were sent away without any card or appointment. People took their own lives. That's how dysfunctional the system is. You know, the minister can go public and say, we're doing this, stop. The community can be thinking, this is wonderful, our campaign has been a success, we've achieved something, and this dysfunctional system does not bother to tell the people who would actually hand the card out that it exists, that it is a new and a positive step to trying to deal with what's a major issue in this society.
Is there any light in this tunnel in terms of good practice in relation to?
There is good practice, but it isn't systemic good practice. This is a dysfunctional system. Before, I think it was during a period, from direct rule, 2000, 2001, our government was suspended about 7 times, and each time the British government stepped back in again to take direct rule. And during the first period of our own government, one of the very important initiatives was a big consultation exercise on how you might reorganise the health service here. And a model was produced that virtually everybody in this society signed up to. But the government was suspended, direct rule was in place, and a tragedy happened. One day from a hotel in Belfast where the direct rule health minister announced a new health model, and it was the English model, the one that nobody had been consulted on or signed up to. And that's how come we ended up with the 6 trusts. They should have gone, in the other model they would have gone. We had hoped that our new model would have got rid of the commissioner-provider split. There is no need for it, and there's very clear evidence it adds 15% onto the cost of healthcare delivery in our system. the crazy thing that happened was that these providers were established, but there were no commissioners set up for another 2 years. So the current healthcare board was 2 years later, the current PHA was 2 years later. So it was, people were running riot in terms of what was happening inside the health system. It had been let loose. It was set up on what was described to us by the Department of Health as a lateral system of management, which we thought would probably work very well for the delivery of medical care, but does not work at all if you need the toilet fixed in an A&E department, because they stripped out the managers from every hospital. You know, the buck stops here manager, the senior manager, there are none. That person is not there to run. You can't get a window fixed, you can't get a toilet fixed, you can't say, I'm holding you responsible for what is happening inside this hospital. It's this diverse system where everybody blames everybody else. It is completely dysfunctional. It has been, and we have been negotiating for 7 years now about steps that could be taken to correct some of these matters. If somebody's actually responsible and buck stops here, then things do get done. If nobody is, and anybody can pass the parcel or blame anybody else in the system, nothing gets done. If the current Minister for Health is opposed to a human rights framework, which he has publicly stated he is, then that travels through the system. And even people who might have been supportive 7 years ago about a human rights framework for health policy and healthcare delivery now feel that they can sideline that. So, you know, from the really big important things to fixing the windows in the health service, we're in trouble. I have been working with our health system for over 30 years. I have never known it to be so dysfunctional.
I'm conscious of time, so I'm going to pass. Marin, are you happy to pass?
I think
on the
Paul
floor?
wanted to
Yeah,
say
just
something.
on
If
a
you could be very brief, because I'm very
Yes,
conscious
it's
of
okay,
allowing
just 2
Paul
minutes.
time to
Sorry. On a
get
positive
questions
note, when we were in the city hospital and the city hospital was closed, when we were in dire straits in the city hospital, there was and the staff nurse came in from the community to be a liaison officer. Her name's Jackie Keys. She's nice sister Keys. Jackie Keys set up a thing to take the pressure off any departments to bring people out to the community for her team to look after. Now, it's a meltdown now. Jackie has built up a team who, without them being there, this system would be in a far worse state than we're telling you now. So these girls need a credit where credit's due.
Can I just on one last note? Sorry, there's very good care out there, and that good care is getting delivered by every member of staff that is working there right now, right today. But it's very hard as a nurse to deliver that care when you've got one hand tied behind your back, and that's exactly what's happening to nurses. You feel like you've got one hand tied behind your back, and you've got one hand to do your job, and that's impossible to do.
And a very brief concluding observation. There is good work applying the Daming principles to control of variation. Those who are leading that work have been very clear to me. They will not raise the 4-hour performance beyond 80% by doing it even in 2 to 3 years' time. And it does not address the root causes around staffing, beds and bed occupancy we put forward in our evidence.
Thank you very much.
Okay. Paul.
Many thanks for all the remarks from all of you. First, may I just ask about an organisation that I don't think you've commented on? If you did and I missed it, I apologise. But I'm interested to know if you have a view about the RQIA. I noted that you commented that the PHA has not been good at its quote challenge function, and I got that point. I don't know if you were in the room when the RQIA
We were.
spoke. So
yeah.
I'm interested to know whether you feel that the RQIA is an important part of the accountability process within the health system, and whether it's fulfilling that responsibility.
We just met with the RQIA a couple of weeks ago, and we've just sent them a draft memorandum of understanding, which we'd like to sign between them and the union.
Yeah.
What we realise with the RQIA, it was the real problems in the delivery of private sector home care that brought us to their door. What we realised at a very early stage was that the RQIA sees things when it goes in to investigate that are made available to it by the system, and we see other things that are not made available through the system, not the least things like rotas and how work is really delivered and how much time is really made available. So we talked about the necessity to find a safe way of people being able to give that information. Sometimes it goes in unannounced, very often it goes in announced. Now we all know that whether you're talking about the public health system or the private elements that it procures with, if an announcement is made that an inspector is coming in, oh my goodness, staffing levels go up, quick redecoration happens, plants are planted outside. You wouldn't recognise the Royal Victoria Hospital if there's a royal visitor. It's extraordinary what can happen in a 24-hour period that cannot happen as in a normal part of the system. So there is that problem that much more spot investigation needs to take place, and there needs to be more sharing between the people, and there needs to be a feeling of confidence between the workforce and the investigatory body, given that everything else that we've said, that they're not going to get into trouble. So we hope the Memorandum of Understanding will go a distance. We think the RQIA needs to have a bigger conversation with us about human rights and a human rights based framework. We think the whole system does, to be honest, because outside of the equality and human rights managers employed inside the system, nobody else appears to have the knowledge or the expertise, whether the commitment is there or not. And it was one of the things that the system was supposed to be training itself in. You know? So there's that. There is suspicion that the RQIA is seen as part of the health family, and therefore is it truly independent when it goes in. And there is an issue, and you know we've shared this with them. We're not saying any talking out of school to you, that minimum standards we don't think are good enough. There needs to be a lot more work done on what the actual levels of standards, what are the international standards that should be applied, as opposed to minimum standards.
The RQIA report interim on the Belfast incident was a rigorous document that UNISON supported line by line implementation. The final report was a very weak document that we think was unduly influenced by financial pressures from the department. It doesn't cut the mustard, it doesn't address root cause, and we were very disappointed in the final report on accident and emergency.
When the RQIA came into the Royal, they basically put it out around the department that they were willing to speak to absolutely everybody who had a comment to make. I actually joined the queue to have my say. One of the very important issues I raised with RQIA, and they're always banging on about it, is infection control. I think it's probably a better part of about 8 or 9 years ago when Colin Clark was infection control nurse for the whole of the North, that we had a meeting with him and his layout of what way he was going to run infection control within the hospital, and how he was going to punish nurses who didn't wear the right apron when they were serving food, who forgot to change their gloves because they were really busy running from one patient to the next. It was wonderful to hear him say it. When I said to him that the worst offenders in the trust for breaking infection control regulations was the porters, everybody thought I'd lost the plot. And he asked me what did I mean by that, Darren. Dead simple. We do not have a patient-only lift in the Royal Hospital. We have 13 lifts down the corridor and we can't get control of one of them. So if we're bringing patients in who need to go to theatre emergently, they start in the corridor and they join the queue like everybody else. Now, when I raised this issue at a very senior level with lots and lots of people, I've been banging on about this one, they were told that in relation to the allocation of lifts and etc. for the duties within the hospital, everything was being adhered to. If you're emptying bins, you can have a key to get control of a lift, but if you're taking a patient who's critically ill to a theatre, you stand in the corridor and wait. Our QIA were informed that we still to this day demand a patient-only lift for all patients, not for A&E patients, for any patient accessing that hospital, and we're still waiting for it.
Minimum standards.
I'd be really interested to know, but maybe it's something that can be done by way of writing and follow-up from you or others or whatever, but I'd be interested to get crystal clear what the key obstacles are to greater acceptance of a human rights-based approach. And I'm hearing a number of obstacles. One is a question of leadership. It's what the minister said some time ago. That's one. But I would be, I mean, maybe now's not the time, but at some point it would be really helpful to get clear what are the key obstacles to a human rights-based approach. But could I go on to another point? And I'm sorry we have to be so brief, at least now. Is the role of the commissioning board to address some of these problems, or is it too much part of the problem? What's your view about this? I mean, Jonathan, if I caught it correctly, you're a participant observer of the board?
I sit as a member of the public, the only member of the public on many occasions.
Okay.
I do speaking rights on behalf of the union, where I talk to the wall and receive in silence.
Right.
I listen to their performance and finance reports. The performance reports state the 4-hour and 12-hour performance of A&E. Non-executive directors are getting increasingly restive, but have clearly not historically been encouraged to challenge. There is no root cause, there is a culture of blame, and there is a culture of defensiveness. So in my view, the board is not advancing the issue by facing up to the underlying root causes we've said, and I think there's a historical protection issue around that from previous to chief executive in my view. So I don't think the board acts in a way through its governance that acts on behalf of the people and of those who deliver the services. I think their governance, last point, is not the generative governance that Obama did in Chicago South Side. It is very restrictive, very closeted, very tightly locked down.
Well,
and until that changes, I don't think this issue changes.
That leads me to what maybe should be my last question. I mean, I'm very, and you, if you think my question is misplaced, you'll say without hesitation, and I need to hear that. If you think it's a misconceived question, I'm conscious that I'm hearing very clearly there's a problem of culture. I understand that. There's a problem of a scarcity of resources, insufficient funds. I understand that too, and you've made some other really compelling points. But my question is that it's related to Jonathan's last point. It's a question of governance. Mm-hmm. Whilst trying to improve the culture and whilst struggling for more resources, is there something practical, achievable, doable that could be done to enhance the quality of the governance? And by governance, I'm talking about enhanced participation, enhanced transparency, enhanced accountability. And I suppose, and this might be the bit that you don't like, but I'm not talking about sort of sweeping away the current system and starting again. I mean, that discussion needs to take place, okay? Don't misunderstand me. But what, frankly speaking, what can an inquiry panel such as ours, what can we constructively recommend in order to deepen the participation or the transparency or the accountability in relation to the governance, which is back to Jonathan's point? Is there something practical, concrete, specific you would wish us to recommend?
Well, I think it does go back to your question on what's the attitude to equality and human rights. A genuine model of public health is what we are seeking. The system demonstrated in 2001 that it had a plan for achieving that. We want to work with the system to get that plan put into place. We have given very positive evidence to the system itself and indeed to the Assembly Scrutiny Committee, the Health Scrutiny Committee, as to various ways that could be done. It does take collaboration across government and across public service, but it's needed. It's a small place, 1.8 million people, real problems, they could be put right. So that's the first thing. There is a genuine problem about the tiers and the layers, and the fact that attempting to get to the place where the decision is made in order to influence it is like peeling an onion.
Right.
And something needs to be done about that. And there has been, in the last 2 years, a tendency to create new tiers in the system which now meet behind closed doors. So those are not public elements of the system, and they were never in the system in the first place.
So Patricia, if I may, to push a little bit, if I can, because I really would value your views on this. So if I caught it correctly, Jonathan, I think implied in your remarks was there's real, genuine public participation in the commissioning board. Is that a fair summary?
No.
Oh, absolutely not.
I'm the only member of the public present.
There's perhaps I phrased it incorrectly. What I was trying to convey was that there's inadequate public participation in the commissioning board. That was what I was trying to convey. I'm sorry I wasn't clear. Evidently.
Could we just say that we've forced the board to meet in rooms big enough to allow more than 5 members of the general public to be present?
Okay. So what I was trying to get to was, is there a sensible recommendation to be made that the commissioning board and indeed the trusts, they should, and I don't know quite how, but they should be somehow much more open to public participation.
Yeah.
Now, exactly how that's organised is complex, but is that something? It doesn't go back to your 2001, I think it was, public health model. It's not that, but is that one sensible, practical way of enhancing public participation to create a bigger space for public participation on trusts and the board? Is that a way forward?
Yes. Boards, officers and trusts and board members and trust board members, same space, mandate, produce a plan to improve care. Second mandate, deliver human rights in this function. Independent chair. The toughest job, maybe even George Mitchell comes back. But until it's done that way, we have different organisations effectively throwing rocks at each other. And it is not productive, and it is not in the interest of the people or the workers in these functions.
Is that written down somewhere in a UNISON recommendation or briefing or report or anything?
Yes, and I think particularly in the ideas we had around the role of the Public Health Agency, because the Public Health Agency currently works with a very large number of community-based groups, many of whom are members of our union, most of whom are facing loss of their grants or their contracts at the minute as well, which is very disturbing. A much greater and more effective use of that process, because that is what the system did back in 2001 in order to encourage the direct engagement of all sorts of people across society and what a health model, what the needs were and what a model might look like. That's actually not hard to do, because we've been doing it for many, many years in this society.
If we haven't got it already, perhaps we could be sent that briefing of UNISON.
Yes, we'd be very happy
I'd like to read it for my education.
We'd be very happy to.
Okay, thank you all very much.
Thank you.
Thank you.
Okay, before I wrap up, final opportunity, is there anything we've not covered or anything that any of you want to say just in conclusion? And I am going to say be brief, but give every one of you a chance to do that.
There's
Ray,
one
clearly.
final comment that
Yes.
I would like to make, and unfortunately we haven't touched on it so far. We've fallen through the circumstances of transforming your care. And let me be totally clear, from a frontline member of staff's point of view working within the health service, savings have been made at the expense of the acute side of health provision in Northern Ireland to pay for transforming your care. Those savings have been put against the balance sheet and budget and balancing the books for trusts
It hasn't been reinvested within the community side of the house. Therefore, we have people being discharged from hospital without adequate care, without adequate provision. They end up coming back into the system more acutely ill, waiting longer and staying longer, and it's a vicious circle that we're currently in.
Just a final comment. We heard what you said, Chair, earlier on, I think, maybe to PHA, when you said you would take more written. We have volumes. We just very actively engage with the system, with comments, with ideas and submissions. It's where to draw the line, but we'd like to send some of them to you to give you a flavour of. We're painting a very poor picture, because it's a poor picture out there, but we love this service and we will make this service work, and we've got really good ideas as to how that should happen, so we'd like to share them.
Yeah. Well, that brings me very neatly, unless anyone else wants to finish it. Owen, and then Jonathan. Yep.
On the governance issue, you asked the question. What I would say to the Trust is they started making changes 5-6 years ago now, and most certainly them changes that they made hasn't made anything better for the public or for the staff that's working. So I'd ask them to stop right now, because there's loads more changes that they want to make, and none of the changes have made things better. So I ask them to stop right now, reflect on what they've done, and get into proper negotiations, not just with the staff representatives and the patients, of what service that is required to be delivered to the people of Northern Ireland.
The recent letter from the Permanent Secretary to Trust Chief Executives stated that they were accounting officers, they must balance the books, and there will be no bailouts. 4 of the trusts started this year already in deficit. Nobody is talking about the statutory duty of care that Trust Chief Executives have under the legislation that created the current trusts. Trust Chief Executives, to deliver that and to support human rights, must be equally and publicly supported by the department and the board in delivering that statutory duty.
Absolutely, and the Southern Trust, in response to that, sent a letter to every one of its staff yesterday, cancelling all training. So, where are we going to get the human rights and equality training from?
Okay. What I'd say then, look, thank you, that's been really helpful. It's really important to us that we hear voices from within the system, and I've said this as well, particularly to patients and their families who've given us evidence, and it's really important that we hear voices from staff on the ground. We'd be delighted to take additional submissions. We've said that to everyone. The important thing, I think, for us is that this is a human rights inquiry into the emergency department. We don't see ourselves, unfortunately, much as we might love to be able to do so, to resolve all NHS issues in kind of healthcare and health and social care. So the important thing for us is that the evidence you get is the evidence around the emergency department, because that's the reality of what we're looking at, and any of the evidence of the issues about human rights in particular are really important to us. But we do recognise that the emergency department is not just about what happens in the emergency department. We do recognise that, where patients and how patients come in, and where and how patients come out, and the relationship with social care, the issues of governance are really quite important. So, but that's the basis on which the terms of our reference are. So we'd be delighted to get some of that stuff that you've obviously already worked on very considerably. And it just remains for me to say thank you very, very much for coming in this afternoon. It's been really useful to get that sense of what's happening on the ground in emergency departments and a UNISON perspective on emergency care and the healthcare side, particularly on the governance as well. So thank you.